and is now it's chaired by Dr. Khalid Najmi. To start with, I will like to call Dr. Sharif Hashmani to be the first presenter of the day.
I would invite you to the one-day symposium that is being held in Karachi on 26th of January on retina and diagnostics at Hashmani's Hospital, Karachi. Now we start with the implantation of toric IOL and addressing the corneal astigmatism. The most important in today's world, जब पेशेंट्स आजकल बहुत ही ज़्यादा डिमांडिंग है, ज़रा सा भी 0.25, 0.5 भी अगर नंबर रह जाता है तो वो ऑब्जेक्शन करने लगते हैं. और सबसे बड़ा जो मसला है वो सिलेंडर्स एंड एस्टिग्मेटिज्म का, कि आप एस्टिग्मेटिज्म को कैसे एड्रेस करें. तो पहला तो ये है कि विच सिलेंडर हैज़ टू बी एड्रेस्ड, the manifest refraction or the one that given by topography or one that is given by our A scan जो हम जो करते हैं IOL master वगैरह. तो शुरू में हम मैनिफेस्ट से भी करते थे, लेकिन रिजल्ट्स हमेशा वो क्रिस्पनेस नहीं आती थी जो आनी चाहिए. So now this is international standard. You have to do it with the topography given cylinder. And the other ways of addressing this is limbal relaxing incisions or opposite clear corneal incisions or toric IOL. So हम बात ही करेंगे अब. So this is the toric IOL, and you can see a mark on the toric IOL, and this has to be aligned with the steep axis of the cornea. And keep it in mind that every 3 degrees of rotation, there is a 10% loss of power. So अगर आपका 10 डिग्री का रोटेशन है तो आपका 100% ये आपका तकरीबन 10 डिग्रीज रोटेशन पर आपका तकरीबन 33% लॉस ऑफ पावर हो जाएगा. So as I told you, we have to take into account the corneal astigmatism, the one given by the corneal topographer. And there are 2 ways of marking the axis. सबसे बड़ा ये प्रेजेंटेशन बनाने का मकसद यही है कि आप जो हम लोग करते ही हैं कि पेशेंट को बिठाया और मार्क कर दिया उससे आपका ये मार्कर से, लेकिन मार्कर का मार्क जो है इस नेवर वो. और एक स्टडी आई है जिसमें यह है कि 26% ऑफ द रिजल्ट जो आपके मिसअलाइनमेंट होता है, दैट इज नॉट बिकॉज ऑफ कि वो लेंस रोटेट्स, इट इज़ बिकॉज ऑफ कि यू हैव नॉट इम्प्लांटेड द लेंस राइटली. सो एक तो है मैनुअल और दूसरा है डिजिटल. तो मैं आपको सारा ये मोस्टली आई विल शो यू माय प्रैक्टिकल वर्क. एंड दिस इज Virion, and I do Virion guided surgery since last 10-12 years. And आप देखिए कि this Virion gives you the exact digital marker, gives you the exact location of your steep axis where you have to give the incision and the side port. ये आपको 2 incision आपने दिया. Then Virion also tells you how much, what should be the size of the rexus. So, and in cases में the rexus size counts. अगर आपने rexus oblong बनाई है, आपका lens is not covered nicely, तो आपका ये जो tilt होता है lens का, that counts a lot. So you have to be very meticulous about making the rexus. और ये Virion की खास ये digital marker gives you exact size of the rexus, और this is how you make the rexus. And we have taken this film directly from the computer and not from the operating microscope. And then after removal of the lens, we implant after removal of the cataract, we implant the lens in. And अब आपको ये पता है कि किस एक्सिस पर डालना है. This is the beauty of your Virion digital marker. और इसमें आप कभी you cannot go wrong. तो दो एक प्रैक्टिकल पॉइंट और बताना चाह रहा हूँ कि आप जब ये रेक्सिस करते हैं तो ऑलवेज पॉलिश द इंटीरियर पोस्टीरियर पार्ट ऑफ द इंटीरियर कैप्सूल, जो आपका रह जाता है उसको आपको पूरा पॉलिश करना है, वरना फाइमोसिस जो होती है वो वहीं से शुरू होती है। ये देखिए मैं पॉलिश कर रहा हूँ, तो दिस इज़ हाउ यू पॉलिश इट एंड ट्राई कि आप 360 डिग्रीज पॉलिश करें। और अब हम 360 डिग्रीज पॉलिश करने के लिए एक इंस्ट्रूमेंट ले आए हैं, डॉक्टर असफर को भी हमने नहीं बताया, लेकिन वो इंस्ट्रूमेंट है जिससे आप 360 डिग्रीज तक आप पॉलिश कर सकते हैं। ये इरिगेशन एस्पिरेशन कैनुला से मैं पोस्टर कैप्सूल को पॉलिश भी करता हूँ। एंड दूसरी एक टिप ये है कि पोस्टीरियर पार्ट ऑफ द लेंस को जो जितना भी आपका मटेरियल ये विस्को इलास्टिक है दैट शुड बी रिमूव्ड। अगर वो आप नहीं रिमूव करते तो फिर ये रोटेशन के चांसेस ज़्यादा होते हैं। और मोस्टली आई यूज इट बाई इरिगेशन एस्पिरेशन कैन्यूला, जिससे मैं ये रोटेशन कंटिन्यू करता हूँ। आई रेयरली आई यूज दिस इज की हुक। आप देखेंगे ये दिस इज हाउ वी कीप रोटेटिंग। ये देखिए आपका ये हमने अलाइन कर दिया है, एंड देन वी कम आउट एंड देन वी आस्क द पेशेंट टू लाई डाउन 6 hours। अच्छा, ये है आपका मार्क करके जो आप करते हैं। तो मार्क जो आप कर रहे हैं वो मार्क इतना ज़्यादा थिक है कि ये मार्क ही तकरीबन 2 डिग्रीज का है। तो ये जो मार्क है, और दूसरी बात ये है कि मार्क एग्जैक्ट आई डोंट थिंक कि ये इस 180 डिग्रीज का फ़र्क भी है। तो इसमें और उसमें ये फ़र्क है। तो आप ट्राई टू यूज़ डिजिटल मार्कर, और इसमें जो रोटेशन की जो चांसेस हैं कि आपका ये पोस्ट ऑपरेटिव जो सरप्राइजेस मिलते हैं, दिस इज बिकॉज ऑफ द तो मार्किंग भी इट्स अ वेरी गुड थिंग। मार्किंग भी ऐसे नहीं है कि नहीं करना चाहिए, बट वी शुड आस्क द पेशेंट स्लिट लैम्प पर बैठ कर और फिर आप प्रॉपर मार्क करें, तो दिस ऑल्सो वर्क्स। बट आई लाइक टू डू इट विद वीडियो डिजिटल मार्कर। और वीडियो डिजिटल मार्कर में एक और ख़ास चीज़ ये है कि इसमें आपको सेंट्रेशन ऑफ द लेंस भी देता है कि हाँ इफ़ द लेंस इज सेंटर्ड और नॉट। तो और पेनऑप्टिक्स में या ये जो मल्टीफोकल लेंसेज हैं इनमें आपको सेंट्रेशन काउंट्स एंड so take home messages, the capsular access should be very good, number one. Number two, you should clean the posterior aspect of the lens to remove all the viscoelastic and meticulously created wound. तो ये सारी चीज़ें हैं जो आपके रिजल्ट्स को बेहतर करती हैं। चलिए, थैंक यू।
सर थैंक यू वेरी मच सर, काफ़ी मुश्किल सर्जरी को काफ़ी आसान बना के दिखा दिया आपने. द नेक्स्ट इज डॉक्टर आमिर इसरार इफ ही इज प्रेजेंट अराउंड. डॉक्टर मुश्ताक खटक फ्रॉम Peshawar. Dr. Mushtaq Khattak from Peshawar, and he will discuss emerging trends in refractive surgery.
Bismillahirrahmanirrahim. My topic is emerging trend in refractive surgery. First, introduction. Imagine a world where glasses and contact lenses are thing of the past. Today I will discussing brief history, emerging trend, artificial intelligence and refractive laser technology. Brief history. Birth of a modern refractive surgery in 1970. First started with radial keratotomy. Advent of a laser technology in 1980 and 90. In 80 PRK and in 90s LASIK surgery. You all know about the PRK and LASIK. Evolution of PRK to trans-PRK. PRK and trans-PRK are both type of surface laser vision correction. They differ in their technique and approaches to remove the corneal epithelium. They differ in their technique and approaches to removing the corneal epithelium. If we look at the table, epithelial removal in PRK is manual or with alcohol swab you are used. And in trans-PRK, there is no touch of the cornea. Directly you apply the laser. First you do the PTK and then do the therapeutic. Comfort level in PRK is a little bit more discomfort, while in trans-PRK it's less discomfort. Healing time, it's longer in PRK, while in a trans-PRK it's faster. Precision, it's surgeon dependent, while in trans-PRK it's more consistent. Safety feature wise, if you see higher risk of infection because you remove the epithelium, while in case of trans-PRK there is reduced risk. Evolution of LASIK to customized LASIK. If we look at the customized LASIK, this is a topo-guided LASIK. But topo-guided LASIK only needed in certain patients. Not all the patients need topo-guided, because those patients who have irregular astigmatism, you can go for Contora or for topo-guided LASIK. It's only 10%. And only 10% of those patients who have irregular astigmatism and you do the topo-guided LASIK, then only one line improvement usually occurred. The another invent is Press Beyond, which is blended vision. They use the micro anisometropia and increase the depth of focus, and the blended zone is created, so the far and near vision is corrected. Emerging trend and evolution of SMILE. Why it matters now? Increasing demand for minimally invasive, precise and fast recovery procedure. Lenticule creation in 30 seconds. And the machine which is used is Visomax 500. If you compare the PRK, LASIK and SMILE, a laser which is used in PRK is excimer laser. In LASIK, both the laser are used, femtosecond and as well as excimer laser. While in SMILE, you use only one laser, femtosecond. If you look at the flapless, PRK is flapless, LASIK is not flapless, you make a flap, while in SMILE, this is flapless. A bladeless, yes. Small incision, this is only in SMILE. A recovery time, it's LASIK and SMILE have a quick recovery. FDA approved all the three procedure. Emerging trend in SMILE to SMILE Pro. In SMILE Pro, what sets SMILE Pro apart? Stand for SMILE Personalized Refractive Optimization, emphasize precise smart robotic assistant, centration and centraline, cyclotorsion alignment means acroline, maximum laser repetition frequency is 2 megahertz. It's a too fast machine. Here is this video. Okay. SMILE Pro feature is highly versatile. And it can correct up to even minus 14 diopter of myopia, 6 diopter of astigmatism, as well as plus 6.5 diopter of hyperopia as well. Up till now, it's not started in Visomax 800, but in the near future, they will start also hyperopia as well. Robotic central line, acroline, part size 1 micron, track distance 1 micron, you can decrease it. Short suction means 9 seconds is only needed. So suction loss, which usually is a big problem. Patient usually move the eye during suction. So it has a short time, quick visual recovery. Challenges and future perspective, current limitation, patient selection, enhancements. Enhancement usually is not possible in SMILE Pro. And retreatment. Retreatment you can do only means a flap creation, circle, and then you will use the excimer laser. But again the SMILE procedure cannot be done. So if there is regression or there is a need of retreatment, then in SMILE it's not possible. What's next in refractive laser procedure? Customized lenticule design. Potential for hyperopia correction. Customized SMILE Pro. I think some of the people need customized like topo guided, but it's still not available in SMILE Pro. This is our data, and we have up till now done 550 cases on SMILE Pro, and 95% patients are satisfied, and 99% patients are free of glasses. And we will soon present this data. Thank you so much. In hyperopia? No, it's still not available in SMILE Pro. Yes, this is, but this is not now FDA approved. Is the FDA approved, then they will on in our machine. But we have not done that. Yes, they are myope. Yes. Up to 4 diopter. Yes. But I think we can correct up to 6 diopter. Yes. Actual experience up to 4 diopter. Yes. Yes. There is somehow a learning curve. Initially, when we started the SMILE Pro, the results were not as good. But with the time, we understand that there is a learning curve, how much you do the manipulation of the cornea and how you remove the lenticule is you become expert, then the vision is usually 6/6 next day. Um, uh, we have not calculated exactly, but I think 95% cases get 6/6 next day. Yes, it's as good as LASIK, but in LASIK, I'm doing LASIK as well. But in LASIK, you have means when you do the LASIK, there is somehow stress in your mind regarding the flap. And when I'm doing the LASIK, it takes a lot of time and the manipulation of flap, two machines are used is compared to one spatula and you remove the lenticule with the one spatula and as you remove the lenticule, the patient is all right. Yes.
Sorry.
As after femtolasic. Femtolasic has got really very, very wow effect.
Yes.
Smile overall, I say that it take about 5 days to 10 days for the patient to get equivalent visual vision as compared to the first day of the femtolasic. And that wow effect is much less, although there are patients who can see 6/6, 6/5, next day both eyes open में अलग-अलग नहीं करता, मगर they are about 40 to 50%. So we have to be very, very clear about it. So compromise जो है ना, advantage जो है ना वो ये कि flapless है and less nerve damage, dry eyes कम होती है, that I would take as a positive. But not next day. We have to be very, very clear कि हम femtolasic से वो
Yes,
compare नहीं
sir,
कर सकते
you have a lot of experience, 7-8 year experience of Smile. And we have collected this 500 cases just, and we have not calculated exactly. But the one thing which I feel in Smile Pro is about the haze. The patient, which most of the patient coming to me after a week or so, they complained of haze. There is like a bit what we say, जिस तरह हम वो कहते हैं कि धुंध सा है, धुंध. In a case of Smile, vision is usually 6/6, but patient is not happy because of haze, which is there, and especially in near they feel a haze. So this but I have not exactly calculated the data, and you have a better experience.
You want to ask them question?
The data that we have seen in terms of visual recovery, it seems a bit contrary to the international data that we come across. I just wanted one thing. If you can kindly elaborate a bit more on your learning curve, because you just said that in the beginning, the visual recovery was not much fast, but now it's next day. So we just want to learn more about your learning curve, that what exactly you have changed over a period of 1 year.
Yes.
In your techniques that has made your recovery so quick.
So initially, when you start removing the lenticule, this is like a posterior capsule. When you start a cataract surgery, posterior capsule is not visible to you for a long time, and then at the end you even see the posterior capsule. This is same like a posterior capsule. You see the lenticule exactly. So initially we were removing the lenticule even in a 10 to 15 minutes, and now I am removing the lenticule within a minute. So there is a huge difference of time as well. And the second thing is how I remove the lenticule. Personally, I am removing I release the cape, and posteriorly half of the lenticule is released and the half is overlap, and one of edge is out from the opening, and then peel it. And this just take 30 seconds. So the manipulation which you do, dissection, manipulation, I think it matters.
In a sense, I would say that that initially it's a steep learning curve. Initially, about after 30, 40 cases, you become 30, 40 eyes. You become so much expert in that कि आपको एहसास ही नहीं होगा कि यार वाकई आप एक मुश्किल सर्जरी कर रहे हैं तो ये जो अभी मुश्ताक बताया कि if it is done quickly and swiftly and you don't wash the pocket, you get really very good results. So our results improve after 30 to 40 eyes, and there is dramatic difference. But still, I would say आशमानी साहब बैठे हुए हैं कि नेक्स्ट डे का वाव इफेक्ट इसमें कम होता है मगर कम होगा एज कम्पेयर टू फेमटोलेसिक मगर 30-40 आइज आप जेन में रखें और फर्स्ट फ्यू कल भी मैंने प्रेजेंटेशन की थी फर्स्ट फ्यू केसेस अगर आप अंडर सुपरविजन करें तो इट्स मच बेटर.
तो डॉक्टर मुश्ताक, ये जो डॉक्टर साहब ने अभी बात आखिरी में जो बोला कि अगर सुपरविजन में करें तो ज़्यादा अच्छा है, तो सुपरविजन के लिए कब मैं पेशावर आऊँ?
Sir, anytime you are most welcome. Anytime.
Dr. Mushtaq, thank you very much.
So, जी sir. Inshallah. Okay, sir.
Dr. Mushtaq, thank you very much for such useful information. Next on the list is Professor Asar Aslam Khan. Sir, if you're around, sir, please come for your presentation. Next is Dr. Muhammad Saeed Khan, and he will talk about nightmares during femtolesic surgery for correction of myopia.
Bismillahirrahmanirrahim. Respected teachers, my teacher Professor Hamid Bhatt, and all the respected audiences. My talk is regarding the different complications which you face while making a flap of femtolesic for the correction of myopia. I have got no financial disclosure regarding the materials and the machine I have used. Our refractive surgery has changed whole of the scenario of the correction of myopia. But if unfortunately if we come across with certain complications during flap making, the patients on the second day will be having no wow effect and he will be highly irritable. So surgeon will be, what will be? He is having stressful day and sleepless nights. So what to do for that? Best approach will be to assess the risk factors. I would categorize the complications of femtolesic into two categories. One are direct and second are indirect. Direct means they are machine related, suction losses, OBLs, thin flaps, and there are certain indirect factors which are inborn errors or inborn in the patients, mean patients having narrow palpebral fissure, they are having flat corneas. Ridge of the nose in our Pakistani population is usually vertical and sloping. So these are the problems which you face while making these flaps. So first of all, the most appropriate strategy will be recognize the complications as early as possible. Keep calm and carry on the surgery. Inshallah, by the next day, you will have a good visual outcome. Most of the complications regarding the flap makings are the thin flaps, epithelial defects, suction losses. Most of the time we face. Decentered or irregular flaps is another known complication. Flap tears may occur, buttonholing of the flap may occur, or OBLs are the frequent complications which you come across. I'll present series of cases. There are a few cases which will come across. First of all, most of the common thing is the subconjunctival hemorrhage. Why it occurs? Because of when you apply a suction ring on the eye, it raises the intraocular pressure 4 times of the normal. Up to 80 millimeter has been reported. So what will happen in cases of the persons who are using contact lens wearers, the capillaries, they occlude and suddenly the pressure is released, they will release the pressure and sudden hemorrhages can occur. The best thing in that will be, patient will be much more having irritable because of it is present on the wide part of the eye. You will have to soothe the patient, you will have to increase your topical treatments for first 5 days, then it will subside away. This is another complication. thin epithelial flap. This is a case of myopia of more than 5 diopter. Here, the surgeon is trying to make the flap, but because of the flap was made of 110 micron, and inadvertently, the entry of the spatula is in the Bowman's layer. It is not in the stoma. Surgeon was novice, patients were having thin flap, so both the factors combined and resulted in this complication. Surgeon is, at this moment, he is of confident that I am doing a flap surgery, but unfortunately it is in the Bowman's membrane. Anterior part of subepithelial flap है. और ये अब जाके पता चलेगा, whenever he will try to lift the flap, it is only the epithelium and the Bowman's membrane, it is not in the stoma. Yeah. So what will be the strategy? The standard teaching is close the case, wait for 3 months, सारी situation patient को explain करें, this was the problem I have occurred, so I have done this case after 3 months with good refractive and visual outcome. Next case, eccentric or decentered flap is another common complication. If the patient is irritable, he is photophobic, or he is having fear in his mind, you haven't explained the procedure properly. On the right side, you can see my hinge has gone up to the limbus. Patient is constantly moving the eyes. Topical anesthesia, which we commonly use in these cases, is not working. In some of the cases, it is not working. And to avoid the epithelial toxicity, you don't put more drops. So what we'll do, I'll try it on the other side. First of all, negotiate the periphery and enter it from that side. Standard teaching is go from 12 to 6 o'clock. So I have followed that. Patient is more constantly moving his eyes. It has occurred because while doing docking, patient has changed his eye position and has not focused to the screen or the light which is being focused. It has gone up to the limbus, luckily. What was done? In this case, after making the flap, the optical zone of the excimer laser was being fashioned smaller to have application of the excimer laser to the stoma so that we can get a best visual acuity on the next post-op day, and was being managed very rightly. Another problem which we come across in cases of persons who use contact lenses for a long time because of multiple uses of drops or as well as small trivial traumas in the stoma, it was difficult to dissect it. So there must be in your surgical tray 15-degree blade आपके पास हो तो आप बड़ी easily negotiate कर लेते हैं और आप rigid या irregular flap नहीं बनाते हैं. Standard teaching periphery पे थोड़ा सा इसको negotiate किया for the entry of the spatula. Secondly, you see on that side, there is bleeding ooze is coming out. There have all of these patients which are using for the contact lenses for a long time, they have a lot of pannus, which normally encroaches to the cornea 1 to 2 millimeter. In this case, it was encroaching to the cornea up to 4 millimeter. Center को negotiate किया spatula के साथ. यहाँ भी मुझे difficulty आ रही थी. So what I have done, 2-hand shake procedures के तहत, I have requested the OT assistant to give me a 15-degree blade and to here comes the 15-degree blade of normal cataract surgery two ends of the instruments were being approximated and was being joined to make a nick. So clean and neat, regular, uniform flap was being made. Inferiorly, I was again fashioning and having a difficulty in dislodging that opacity. So I requested the OTA to give me a venous scissor. You can use corneal scissors, whatever might you use, you can cut it. देख रहे हैं blood कितना ज़्यादा है? So difficult negotiation of the flap from the bed, and secondly bleeding. But in cases of these bleeding, if the bleeding is there, you must have to irrigate this bed at least 2 to 3 times. Usual से ज़्यादा करें with the balanced salt solution. उससे क्या फ़ायदा होगा? Although I haven't faced any of the complications regarding the deep lamellar keratitis, which is a non-infectious interstitial or lamellar keratitis, but do happens because of the infiltration of the WBCs and blood components in between the flap and the stroma. So to avoid it, I have got 2 strategies. First of all, irrigate the bed frequently. Secondly, I often give the antibiotic steroid combinations or topical steroid for QID, but in these cases, I'll double it. I'll give it for 8 times for 1 week to avoid the lamellar keratitis. Difficult docking. Another common problem which is being faced by the refractive surgeon is difficult docking. What will happen? Because of the small palpable fissures, deep set eyes, flat corneas, lid squeezing. All these our refractive patients are young patients. They have got a good lid squeezing because they have got a strong orbicularis function. So what will happen? It will be very difficult for us to apply the suction ring or the apparatus on that on the cornea. In some patients, I don't know, anesthesia, topical anesthesia is not working. So in this case, my strategy is to use verbal anesthesia. पहले से उनको तैयार करना शुरू कर देता हूँ, थोड़े से आपको प्रेशर पड़ेगा, थोड़ी सी आपको दबाव आएगा, फिक्र ना करें, तो उससे पेशेंट बहुत सूट डाउन हो जाता है, उससे उनका फियर और उनका फोबिया एलिविएट हो जाता है. सो उससे वो फिक्सेशन बेहतर हो जाती है और उनकी डॉकिंग हमारी बार बार हमें करने से प्रॉब्लम से बच जाते हैं. My last case is post-traumatic refractive error. This was another case where I felt very difficulty while doing the docking. First of all, see the case. This is a case of a trauma. आप देख रहे हैं कि ऊपर ले मैंने वो बर्ड रखा हुआ है. At superiorly, the iris is absent. There is a scar mark below my waxel sponge. This was a young lady working in her house. She accidentally penetrated a sharp object into her eye. There was a wound of entry at superior limbus. She reported to us with a history of pain off and on, lacrimation after 4 weeks of the trauma. So I found that the iris was being tuckled between the at the wound, corneoscleral wound. So after 4 weeks, it was necrotic and it has to be abscised. So I abscised that iris, which was being incarcerated in the wound, and applied 2 stitches. What will happen? Patient developed a problem of diplopia, uniocular diplopia. She was complaining, I feel an image along the things which I see from that eye. So on autorefractochromometer, it was come out to be minus 2.5 cell. Irregular stigmatism usko develop ho gaya tha. So I offered her to correct that, your shade while watching your close mobiles or any book, you can be offered a refractive surgery. So she opted for that refractive surgery. So in this case, although the docking was difficult because of the irregularity of the cornea, but we done this case very nicely and patient got a good optical and refractive outcome. So most of our cases in the refractive surgery are binocular. This is a case of monocular astigmatism, post-traumatic, which we corrected by means of a femtolaser. For an evidence-based practice, you must have to review the literature. When I reviewed the literature, I found that there are various complications with the Zimmer, which we perform here in Lahore, LDV, Zimmer LDV, So LASIK flap creation with Zimmer femto laser in 787 cases, that was being published in Journal of Refractive Surgery. They reported nearly 2% of the cases refractive flap-related complications. And in the large 10-year Romanian experience, they reported 1.3% of the cases they have flap-related complications. So this was evidence-based. Things do happen. You don't have to get, you can say, you got problems everywhere, but if you carry on the things, you can get a good visual outcome. So although the femto laser is one of the safest procedures with the fewer complications, but you do come across with these, go ahead. You can have a good visual outcome if you manage it at time, and already published data supports our observation, and you can say bye-bye to the glasses if you think and act vigilantly. Thank you very much.
Sir, thank you very much, sir. Sir, any questions from the audience? 2 to 3 minutes for the question answer session. Any questions? Sir, thank you very much, sir. The next is Dr. Zafrul Islam from Peshawar, and he will talk about phakic IOLs, the current trends.
Thank you, Chair. Good morning, dear ladies and gentlemen. My talk is on the current trends of phakic IOL. Actually, me and late Dr. Nakash started together this procedure in 2011. And we did our first instruction course in Karachi, just in, I think it was 2012. And we tried to convince people that it's a very good procedure. It took us 6-7 years. Now trend is changing, and now more and more people are doing like Ashmani is doing, like Dr. Munira is doing, Dr. Amjad is doing, and there are many more people who are doing it. So this is one of the trend with all of our efforts are, maybe हमारी efforts now खुद ही वो convince हो गए, उन्होंने शुरू कर दिया. बहरहाल the phakic IOL are of two types currently, PC phakic IOL and iris supported. The one I am using is ICL from the Star company, and Artisan Artiflex I have never used it. Ashmani has very good experience of that. He will talk about this. Indications are high refractive error where laser is not possible, stable or stabilized keratoconus, post-laser ectasia. Again, one of the important indication is the patient not willing for surgery on the cornea. This trend is now coming forward because of success of the ICL. And defective epithelial regeneration as the indications, and dry eyes. These are very pertinent indications. This is the evolution of ICL from 1993 to now this time, and in 2011 they introduced a small hole in center of the lens. That was the change, and now the new trend is the preloaded, which is introduced in 2024. I will come to that. ICL is designed as such that it's convex anteriorly, so that it should not be in contact with the crystalline lens. And the advantage of that is, I'm showing it on one of my patients. This is the OCT, this is the posterior part of ICL, and this is a crystalline lens, and this distance is called vault. The ideal distance is 500 micron, and it decreases slowly with the time or with the accommodation. So it's not touching the crystalline lens so as to reduce the chances of the cataract formation. Then again, ICL has got 2 holes on the haptics for centration and 2 holes near the optic for flow. And then in 2011, as I was mentioned, they introduced the small hole in the center, which is not affecting the vision. It's only 360 micron. But the advantage is that the flow of the aqueous has improved. There is no need of prior iridotomies or during operation iridotomy, and again metabolism of lens has improved a lot. Patient workup, the most important thing is anterior chamber depth. Initially it was about 3 millimeter, but with the introduction of aqua hole, now we can come up to the 2.8 millimeter with ICL. With the artisan lens, iris fixation lens, it should be 3 millimeter. And I see that means from endothelium to the crystalline lens, remember it. And then white to white, you measure manually, and with IOL master, both you have to send. This small video, the most tricky part is because this lens is very thin in the center, so you just can't hold it with some metallic forceps. They supply this foam tip manipulator, and you just put with the help of that inside the cartridge. And with a specialized instrument, you hold the haptic. Haptic you can hold with metallic end, and you pull it into the tip of the cartridge. This is that forceps. You take it in, hold the plate haptic till the edge of the optic. So hold should be good, so it do not give way. And near the tip, you leave it, you prepare it first, and then you can give the incisions and try to, this is the incision, it's 2.8 to 3.2. At the moment I'm doing 3.2, but new cartridge you can enter with the 2.8. You go very slowly with tapping incision. And when about 50% to 60% ICL is inside the anterior chamber, you wait for it to open, and you see that marker on the right side of the plate haptic, that is, it's not upside down. It never happened to me in my cases, but there is a possibility. Then you have to remove it and ask, and then ask for another one. So you inject it to anterior chamber, and with the special manipulator, you tuck the haptic behind the iris, and then you put the myocall, and then everything will be really good. So results, I mean, happiness rate is 25%. I won't go into it, but I will come to the new trends. Then one of the new trend is to get a good vault. Now they are doing sulcus to sulcus measurement by UBM, by optimized artificial intelligence technology. Artificial intelligence is coming everywhere. It's very useful, although it is very scary also, that you can see, you can actually measure, and then you can get whatever vault you want. So this is one of the new trend which is coming forward. The other new trend is that more and more manufacturers are coming, like I am giving you example of 3 manufacturers from India, Apasami, Care Group, iCrill, they are all coming up with their this phakic ICL, and I hope it will reduce the price. We don't know the long-term results yet. And another new trend is the for presbyopic, they are introducing the multifocal PC phakic IOL. But there is a problem in one of the recent report, which is published 2024, that they deteriorate the optical performance. So still a lot of work need to be done in this. Another trend is that they have compared the PC phakic IOL with the iris supported IOL, and they have found that there was no statistical difference between visual acuity, IOP, cataract incidence, contrast sensitivity, etc. But with one of the report, they have observed that 40% of eyes after 1 year had some reaction in the AC, which on longer run may lead to glaucoma or may lead to endothelial damage. That is one of the problems. There are other problems of iris-supported lens. So shift is occurring from the iris-supported lens, that is again a new trend, to the PCIOL. I mean, Hashmani himself is doing more and more, I think, ICL rather than the iris-supported lens, as he was telling me. I'm not sure. कि अभी क्या वो है, अभी question answer में हमें बताएंगे. Similarly, they have noticed that toric ICL have demonstrated significantly better efficacy and safety indexes after 12 months than toric artiflex. And there is a high chances of the surgically induced astigmatism with the toric artiflex than the toric ICL. So again, the shift is more toward the PC phakic IOL than the iris supported. Iris supported are more other problem, dilatation of people if they need later on disc inclination of the lens, etc. And that is very exciting new development which was first time introduced. They are working for the last few years. And in the SCARES 2024 in Barcelona, they officially introduced this preloaded ICL because the most tricky, there are two tricky parts of ICL. One is the loading and other is the insertion. So one of the tricky part will be over, you will get preloaded. And what they have found is that the preloaded ICL reduces overall procedure time. It shortens the learning curve for new surgeons. So more and more new surgeons will come and do it and enable more consistent ICL delivery in the eye. Again, they have introduced the new trend is that they have increased the size of the optical zone 20%, so less night vision problem, less photodysphoria, and it's making ICL competitive to the LASIK. And new hydrophilic coating, again, ICL has introduced, that is nanocoat allows for the smooth insertion of ICL through small incision. So in conclusion, I have got 6 seconds left. In conclusion, PC phakic IOL, very useful lens when laser is not possible. Exciting new technologies are developing to make it more reliable, predictable, and safe. Extensive, and that is for younger people who are planning to do is that extensive methodical pre-op workup and correct measurements are important to get best result. That is very, very important that you must work on it. It's a tricky surgery. So follow rigorously the guidelines. Thank you very much. Any question? I finished in time, so I can get 2-3 minutes of question answer. Anybody? What about you, Ashmani? Are you satisfied with ICL?
Very much satisfied with the ICL and very much satisfied with the RT Flex and Artisan lenses, both. I started doing the RT Flex and Artisan lenses since 2007 when I attended APAO, and I was chairing a session with Dr. Harvinder Singh Dua, and he was presenting his paper on phakic RT Flex lenses. So I asked him how it is being done, and so he encouraged me that you should do it. So I went to attend the course on implantation of this, and I started doing that. Till date, I have implanted more than on 200 or 250 patients. There is about 400 to 500 patient eyes.
Of ICL.
And in between, जो मेरा जो experience है, जो आप पूछ रहे हैं, तो मेरा ख्याल है 2013-14 मुझे एक सीनियर हमारे कलीग हैं, उसने मुझसे कहा कि डॉक्टर साहब आपको पता है कि एंडोथेलियल सेल लॉस बहुत ज़्यादा होता है उसमें. फिर मैंने स्टॉप कर दिया 2-3 साल के लिए, और फिर मैंने सारे पेशेंट्स का रिव्यू किया, तो एंडोथेलियल सेल लॉस में कोई बहुत ज़्यादा इतना फ़र्क नहीं था. देन आई अगेन स्टार्टेड, फिर ICL आया, फिर मैंने सोचा ICL मैंने शुरू किया. ICL में डाल रहा हूँ, ICL से आई एम वेरी हैप्पी. एंड स्टिल जो मेरे पेशेंट्स आते हैं 2007 से अब तक के जो हुए हैं, तो दे आर डूइंग सो फाइन कि मैं सोचता हूँ व्हाई नॉट कन्वर्ट बैक टू द आर्टिफ्लेक्स. तो कल परसों डॉक्टर दुआ से फिर मुलाकात हुई, तो मैंने उनसे यही पूछा, मैंने कहा डॉक्टर दुआ, आई एम डूइंग सिंस सो मेनी ईयर्स एंड यू आर ऑल्सो डूइंग इट, व्हाट डू यू से? वी हैव कन्वर्टेड टू ICL, but the patients who have been implanted with Artiflex lenses, they are doing so fine. Why not, what do you say? Should we continue using it? And I am still fond of implanting that lens. He said, yes, if you're right, and अगर लगता है कि कोई ICL आप contraindicated है, कोई problem है, तो फिर आप बिल्कुल डालें. मतलब ये क्या, it's a very good lens. So this is his comment. And my comment is कि इतने lenses डालने के बाद अभी तक कोई endothelial decompensation मैंने नहीं देखी. तो this is the message that I am giving. It's a very good lens. अगर आप सारे protocols follow करें कि आपका ACD should be appropriate, implantation आपने सही की है. The biggest problem जो कल भी हमने अपनी जो हुई थी, ये जो अंडरस्टैंडिंग रिफ्रैक्टिव सर्जरी एंड केरेटोकोनस जो हमारा प्रेजेंटेशन थी, उसमें मैंने दिखाया कि द बिगेस्ट प्रॉब्लम ऑफ आर्टिफ्लैक्स एंड आर्टिजन लेंसेज इज कि डिसेंट्रेशन, आप सेंटर्ड कैसे करेंगे?
Yes,
तो उसमें
that's
हमने
very
केस
important.
हमने अपना एक केस दिखाया कि एक पेशेंट का डिसेंटर्ड
Centered.
हुआ था एंड रीसेंटर हमने किया उसको।
Yeah.
तो दैट अगर आपने लगाया सही नहीं है तो ये एक सबसे बड़ा प्रॉब्लम है, अगर
Okay,
उसको आप
thank you.
कर दें तो।
Thank you, Akhil Qazi, क्यों कुछ पूछना चाहते हैं?
Now, down the road, patient has cataract. What biometry would you do? You will consider the ICL inside, or you will do it without ICL inside? One.
With cataract?
Yes, now the patient has cataract with ICL. So, which biometry you are going to do, considering that this is ICL eye or this is eye without ICL? One.
Yeah.
Second is, once you want to do the procedure, how easy it is for you to take the lens 10-15 years in the eye, stuck with the zonules.
Yeah, the question is about the biometry, doing biometry after ICL. This problem is more with the artiflex and artisan, because they are more anterior. When we do biometry, तो बायोमेट्री में जो पहला शेडो आता है ना, वो समझते हैं कि ये क्रिस्टलिन लेंस का है, तो क्रिस्टलिन लेंस इज बिट थिकर, बट फॉर्चुनेटली they have one of the study I was reading about it, and they say with the ICL you can go along with the routine biometry and there will be no problem, because it's very near to the lens. So whatever lens thickness, अगर वो surface को recognize करता है कि this is front of lens, again the difference will be less than half diopter. अगर कुछ जो चेंज आएगी, और वैसे भी हमें हाफ डायप्टर के फ़र्क से लेंसेज मिल रहे होते हैं, और ज़ाहिर बात है ये जो पेशेंट्स होते हैं इनका अगर आप देखा जाए, ये पेशेंट जो है तो इनमें वैसे भी -11, -12, -14, तो उसमें हाफ डायप्टर डिफरेंस इतना फ़र्क नहीं डालेगा. So with the ICL biometry is not big problem. Yes, with the artisan, artiflex it's a problem. So you have to manually do it कि where the lens is, क्योंकि दो आपको initially spikes मिलेंगी, तो आप anterior spike of the lens को आप लेंगे, not the spike of the artiflex or artisan, because they are quite anterior to that.
The refractive procedures done on the cornea.
Huh?
The refractive procedures done on the cornea, the RK, the LASIK, they totally change the biometric calculation.
Yes, वो एक अलग इशू है, and बड़ा ही complicated issue है, because most of the patient haven't got the record of the PRK or femtolasic or smile when they come back for the cataract surgery maybe after 10-15 years. So that is वो इस ICL का पार्ट नहीं है, वो फिर कभी डिस्कस करेंगे. If there are no question, please next.
Sir, please, sir. Thank you very much, sir. Sir, the last presenter of the day, Dr. Majid Malik, sir, and he will discuss refractive surgery of hypermetropia.
Thank you very much for inviting me on the topic. I was already in another session. We all do refractive surgery for myopia, myopic astigmatism very easily. We don't think much about it. But surgery in hypermetropia is subject to think about it. It is different from the rest of surgery by many means. It is a small study sample because the patients are less and we are more guarded about the prognosis of the patients, so we have to do it in limited cases. Generally, the patient's eye underwent surgery was 19 to 40 years. Pointer habit? In this period, Alcon mostly. Range of hypermetropia was from +2 to +4, and manifest and circulatory refraction difference was +3. 3 patients had bifocal glasses, and 4 were LASIK and 11 femto LASIK were done. because at that time femtolase was not available before that for those 4 cases. We have to, think about certain cases. They are different from the routine refractive surgery. Manifest and lateral component has to be considered. Presbyopia and bifocals, because these patients are wearing both types of progressive or these lenses, glasses. So accordingly, we have to consider. Small eyes, the people have generally small eyes with flat and corneal curvatures, and most of them are isophoric, and which converts into esotropia if the glasses are removed. So we have to think about these cases first and guide them accordingly. People should have stable refraction for at least 3 years. We should carry out full cycloplegic hypermetropy refraction. होता क्या है कि हम normally refraction करते हैं and we go for surgery. In myopics, we are not much considered about this cycloplegic refraction, except the people who use SS accommodation. उनमें आप कर सकते हैं this cycloplegia, but in hypermetropes, it is mandatory to carry out cycloplegic refraction, and the correction should be maximal cycloplegic refraction, or whatever is the cycloplegia, add 30% to the routine hypermetropic correction. KMS generally should be less than 50 diopters. As the patient's age, prognosis gets better in these patients because of less accommodation. दोबारा आ गया. These patients are to be excluded because of the unforeseen problems. Any previous laser surgeries, those suffering from acute or recurrent eye diseases and dry eye, of course, we should be very, very careful. Other comorbidities like dry eye, especially allergies, amblyopia, and maculopathies, means we should have thorough evaluation of the patient before surgery. Corneectasia, opacities, degenerations, and histories of viral infections. Esotropia excluded, but we can consider esophoria. Esophoric patients can be considered. Esotropia, it is not good to go for these surgeries. Refraction should be subjective as well as with cycloplegia. And topography. Topography is mandatory. There is no question about a detailed topography and its evaluation on the subject. It carries out a lot of things. Vashmani sir बताते हैं अभी ना epithelial mapping भी हर चीज़ करनी चाहिए. कल discuss हुआ, because there are so many things which are not covered by simple topography. So ideally we should carry out all those things, and dry eye is very important. सबसे आसान काम है स्टेन करें उसको, और डाई क्लियर देखने कितनी देर में डाई क्लियर होती है, तो that gives a good indication of dry eye. If you don't have mapping is generally not available in most of the places. We should go for femtolasic. If that is not available, only then this mechanical or blade-based, microkeratome-based LASIK should be done, but preferably this. So this is the way you remove tissue. Leave the center, apply laser around that, and make an elevation in the center. In these patients, this was plus 1.5 to 3, but with mild hypermetropia and other 10 patients were having a bit higher degree of hypermetropia. Ideally, it should not be more than 3. 3 से ऊपर पे avoid करना चाहिए because the results are unpredictable. Post-operatively, 24 patients, that is 80%, were emmetropic with this minor difference. 5 were a bit myopic shift, and 1 patient was having residual hypermetropia. Not very serious. another important thing is there is a bit of shift, myopic shift initially in these patients if you have fully corrected because of excess accommodation. These people are used to use more accommodation than normal people or immetropic people. So gradually they learn how to reduce their accommodation, and then this myopia returns to normal. It sets in a few weeks. Then, from the patient perspective, generally distance vision is satisfactory, but it takes some time because you have to utilize your accommodation for it takes time because of excess accommodation is in normal regular use in these patients, but they are very good for near vision. So take home messages, always consider latent component, 30% increase in manifest component. आपने अगर जो रिफ्रेक्शन पे ग्लासेस लगा रहा है उस पर दे दिया तो you will be having residual surprises. 4 से ऊपर मैं कभी नहीं गया, ideally 3, 4 वाले भी 1-2 केसेस थे. Best procedure is femtolasic, and early press biopsies are the happiest patients because they find very, very comfortable for reading. Thank you very much. If somebody can add to my knowledge, I will be more than happy person.
सर हाइपरमेट्रोप्स की फेम्टोलेसिक में जो प्रॉब्लम मैंने फेस की है ना, हमेशा जितने भी पेशेंट्स किए हैं, बहुत ज़्यादा तो नहीं किए, लेकिन उनमें जब जब हम फ्लैप उठाते हैं और जब लेज़र अप्लाई करते हैं तो वो हिंज वाले एरिया के ऊपर कुछ, चूँकि हमारा एब्लेशन जोन बड़ा होता है इसमें, तो वो हिंज के ऊपर कुछ लेज़र लाजमी अप्लाई होता है जो हिंज को कुछ वीक कर देता है।
यूनिफॉर्म।
हाँ जी, तो उसके ऊपर फिर हमें स्पॉन्ज रख के फिर उसको कवर करना होता है कुछ इस तरह से, लेकिन फिर भी कुछ ना कुछ हिंज उसमें इन्वॉल्व हो जाता है उसमें।
If
हो जाती है सर।
if you keep your Vexel sponge small piece, cut it to the size of the hinge, and you place it and you keep on looking at it. Said that's the best way because it is working near the hinge, and the patient eye is not stationary. So the patient eye is moving, the hinge is liable to be hit. So after my few cases, I have done cases with 6 diopter plus 6 diopters and doctors, and very happy patients, and they are young patients, alive, now in their 30s. The only protection is, from the first case that I did, was that you get a Vexel sponge soaked so that you can compress it in a small piece and put it on the whole length of the hinge. Maybe 0.5 millimeter towards the cornea, rest towards the flap.
Right, sir. Any questions from the audience, sir?
Because whatever machines we have got, centration is not really that accurate. So as it decentered, तो जहाँ पे थोड़ा सा decentered हुआ होगा उस जगह आप देखेंगे कि आपके एज के बाहर भी आपका लेज़र लग रहा है. तो उसमें my suggestion is, especially for hyperopia, कि आप बड़ा diameter, bigger than what they say, bigger diameter आप flap बनाएं. And that's very important because वही flap जो है थोड़ा decentered भी हुआ तो आपको problem, अगर वो decentered उस तरफ हो गया जहाँ पे hinge है तो फिर वो सारा आपके स्पॉन्ज के ऊपर जिससे प्रोटेक्ट किया उसके ऊपर जाता रहेगा, वो आपको इफेक्ट नहीं मिलेगा. तो ए बिगर वन, तो आप उसमें जो डिवाइस है वो बड़ी वाली डिवाइस लेंगे और बड़ा उसका फ्लैप लेंगे उससे, जो कि रिकमेंडेड है उससे बड़ा ले लेंगे, मे बी 0.5 to 1 millimeter more diameter.
Secondly, they have large angle kappa, these hypermetropes. So the flap should be a bit nasal. That will serve better purpose, apart from being a bigger flap. Thank you very much.
मजीद मलिक साहब, बहुत ही अच्छा प्रेजेंटेशन थी माशाल्लाह. एक कमेंट सर, शायद मैंने मिस किया है, आपने कहा होगा कि द डायमीटर, जो जफ़र ने कहा बिल्कुल ठीक कहा कि हम मायोपिया में 9 मिलीमीटर का फ्लैप बनाते हैं, इसमें हमने 9.5 मिलीमीटर का फ्लैप बनाना चाहिए. तो वो आपका फिर ये, क्योंकि मोस्ट ऑफ द लेजर इज एब्लेशन इज डन इन द पेरिफेरी, तो तो 9.5 मिलीमीटर का फ्लैप से आप ज़्यादा अच्छा कर सकते हैं.
Correct.
थैंक यू वेरी मच.
Thank you, sir.
मजीद
Thank
साहब,
you.
हमारा अभी पैकर्स की मीटिंग है, आपको चलना है.
Yes, sir, thank you very much to all the presenters, especially Dr. Mushtaq and Dr. Zafrul Islam from Peshawar, and the Hashwanis, Dr. Numan, Dr. Sharif from Karachi, for coming to Lahore and attending 42nd Ophthalmo. And I also thank to all the audience to listen this session so patiently. And all the presenters, please come for the photograph. So, बहुत शुक्रिया sir.